So welcome everybody, welcome to our webinar. This webinar is really interesting because it's not only for a teacher of the Centro Universitario de Tonalá, he's also a great doctor and researcher. So please feel free to ask anything you want to. I would like to remind you, I would like to recall you that if you want your certificate attendance, you must be registered in the forms. And the forms is gonna be in the chat in a few minutes. It's gonna be open only the first 20 minutes of the webinar. So please remember, if you want your certificate attendance, you must be registered. Okay, so let's give the welcome to the Dr. Antonio Flores, and let's listen whatever he has to tell us and give us all the knowledge that he wants. Thank you, Tony.
Thank you very much for the presentation. As I'm very glad to participate in this webinar. Since you, Carla, invited me, I didn't. I just think that I want to participate, to share this information with all my students and with all the students from Tonalá or other students from the University of Guadalajara network. So I want to share with you this night this presentation. It is called Cell Therapy and Hematopoietic Stem Cell Transplantation. The title seems to be very complicated, but today, thankfully, it is a reality, and we can do this type of procedures in a daily basis in our patients. Some of you either in the medical field, in the nursing team, in the geriatric team, or psychology or nutrition or whatever the medical field of the health services you are involved in, you can participate in a stem cell transplant team. Well, my disclosures, I don't have any conflict of interest. And this is the objectives of the agenda of the talk. We're gonna share some basic concepts about cell therapy and hematopoietic stem cell transplant. We're gonna see how the view of the world and Mexico situation about transplant, some historical background, and conclusions at the very end, adjourn, and I want to share a message with you to take home. Okay, so to begin with, a transplant is a high technology procedure that uses progenitors, the human hematopoietic stem cells, and can be either autologous, it's when the cells come from the same patient, or a different donor that is called allogenic. These type of procedures can be potentially curative for many malignant and non-malignant disorders. At least 70 different diseases can be cured by a transplant. And so that's like the main importance of these type of procedures. Since the basic or the first semesters of the career, you took one of the subjects was embryology, and you may recall, you may remember that all the hematopoietic progenitor cells come from the mesoderm part of the blastocyst. This layer of the embryogenic blastocyst is the one that is going to form the cells from the bone marrow. At the very beginning, the liver and the spleen are the main organs where hematopoiesis is done. So the blood is produced over there, and it is not until the 16th week or the 4th month of the fetus of the fetus, um, uh, until the 4th month, the blood is produced in the bone marrow. We have a lot of stem cells or different stem cells. We have 3 of them. The most important, or at least the one that we use for clinical or therapeutic procedures, is the multipotential cell. Totipotential cells or pluripotential cells are more plastic cells, so they are more immature. They, as you may see, the totipotential cell is just few divisions from the blastocyst in the post-fertilization period. So these cells can divide and can be like uh, as they are very plastic, they can be induced to form any type of human tissue or organs, like a liver or gastric tissue or lungs or a heart or whatever. But in these type of cells, as you may understand or may think, it is a moral and a bioethical uh, rules that prohibit the use of these type of cells, because we will need to use human embryos um, uh, to and take these cells into a lab and then let them grow as we need to, as a liver cell or gastric cell or any type of tissue. But this is not, there are rules, so bioethics doesn't allow this to be done. So we use multipotential cells. These are cells that are 10 to 14 days post fertilization period, and in this and we find here stem cells that are the ones that we use for stem cell transplant. Stem cells have different properties. One of them is the most important. Is they have self renewal. So if we have a stem cells inside the bone marrow, inside the bones, mainly the large bones have the bone marrow. Um, they can produce a cell that is just identical as the mother cell. So that's very important, because if this doesn't happen, uh, in a time we will like have lack, or we will like don't have enough cells to continue with the hematopoiesis. Other properties, they can differentiate. Differentiates means that they can mature, or they can grow into different type of cells. For example, platelets, leukocytes, or red blood cells, as the body of the person needs. And the other one is proliferation. And proliferations is that they have like this capacity of expansion to repopulate, for example, when a marrow is empty, or when you translate the cells from one body into another body. This is the cell, the main like this cell that is CD34 is like the main antigen that we can find in the membrane of the cell, and we can separate and we can study these cells by procedures like, for example, flow cytometry. We can count the cells, and then we can separate the cells and just like grab from a donor or from a patient these type of cells. How can we do that? There's like different techniques. The most important is apheresis, as we will see in a while. So progenitor cells, the ones we use, are like in between here, and they have a lot of, as you may see, the proliferation is very big. From one cell, you can have a lot of mature cells that have a specific function in the body, and the growth or the of the speed as they grow might be from 3 to 5 days. It's the period in where the cell can proliferate or can be in a mitosis or duplication period. 30 billion of cells are in the human beings. 7.5 times 10 to the 11th are inside, living in the bone marrow. And you see only 0.01% of the cells inside the bone marrow are represented by stem cells. So you can see not only this very small percentage has the capacity or like giving life to millions and millions of cells that in a daily basis have a specific function, like the erythrocytes, like exchanging oxygen and carbon dioxide, or fighting against infections or bacteria in our white blood cells, or avoiding the people or the person to have hemorrhage or bleeding, and the platelets. As you may see, only this very small percentage has the capacity of that kind of proliferation and giving life to another cells. Progenitors that are more like uh, more mature than stem cells are only 0.02% in the bone marrow, and the most of the precursors are 99.8%. And then after precursors, then we have all the mature or the peripheral blood that has a specific function each of the cells. In this timeline, you can see since then late 1950s, the first transplant was done in the world. Dr. Donald E. Thomas from the Seattle group in the US did the first transplant. It was in 1956. It was a syngenic transplant. Syngenic transplant is when you have twins. In that time, they didn't have HLA or compatibility test. So the hypothesis of Dr. Donald Thomas was that if they're like identical twins, then they should be compatible. So one of them was a leukemia patient, and they grabbed bone marrow from his brother, and then infused that cells to the twin that had leukemia, and he was cured by then. Then the group by Dr. Matte in France, in Paris, did a second transplant reported in 1959. And it was not until the 1980s where Dr. Ricardo Sosa's team in Instituto Nacional de Nutrición in Mexico City did the first transplant in Mexico. It was a plastic anemia patient. The results were outstanding, were very good. But we had a period of like 15 years without any advance or in Mexico, at least in terms of transplant. Not until it was the Grupo Monterrey from Hospital Universitario and La Clínica Ruiz from Puebla that performed or invented this method that is called the Mexican method. That is like trying to make transplant at low cost with low mortality rates and as an outpatient patient. So can a bone marrow transplant be done as an outpatient or ambulatory? As ambulatory, yes, the answer is yes. You can do bone marrow transplant without a hospital, without an isolating room, and the rates of complications, either infections or yeah, mostly infections, and are lower or decrease in a very great percentage. Until 2017, more than 1 million of patients has been transplanted. Uh, Only last year, above 68,000 patients were transplanted. Most of them were autologous. So as you remember, we talk about autologous, where the stem cells come from the same patient, and the other 40% are allogenic. This is because it's from another person, like a brother, sister, father, mother, or even a non-related donor. In Mexico, we are doing like maybe between 500 or 600 transplants a year, but we only get a few patients to get a transplant. Only 10% of what we are accomplishing, only 10% of what is really needed. So the other 90% of patients is but they are dead now. No, they need another therapies or chemotherapy or combinations, but most of them are dying in the attempt to get a transplant because the disease relapse or comes back, like leukemias, and well, we are losing a lot of patients, thousands, maybe hundreds of patients are dying because we don't have enough transplants for them. This test that comes from the human chromosome number 6 is HLA. As you know, we have two types of HLA, class 1 and class 2. It's like the genetic code of the patient. We search the HLA in high resolution, either for the donor and the patient, and we can see how compatible they are. Um, First of all, when we need a transplant, we ask the parents, the father and the mother, if they have or if they have like sons or daughters, can be tested for HLA, and then we perform the HLA for the whole family, and then we see if they have compatibility. We need at least well, we search for 100% of compatibility to do a better outcome transplant. But if we don't have 100%, we can do two things. One of them is go for an haploidentical transplant. This is a half of compatibility that obviously the mother, or the mother, the father, or even one of the siblings can have at least 50% of compatibility. But this type of transplants, even though it is we are capable to do that in this time, it is a high risk transplant, a lot of rejection, and another complication that is called graft versus host disease is what we don't want for these patients to happen, because it will like it will have a lot of morbidity, a lot of cost, a lot of hospitalizations, a lot of infections, and even death for our patients. So the source of the stem cells can be either bone marrow, and then we go to the pelvis of the donor, extract from there the stem cells, or we can use peripheral blood. And there's a mechanism that it separates cells that is called apheresis. We can do that also. So the bone marrow occurs only in 23% of the cases. 77% of the cases are peripheral blood, and very few cord blood. Why cord blood? It is not very used because, for example, for an adult patient, we will need at least one cord blood unit for each 10 kilograms of weight of the patient. So, for example, if I weigh 70 kilograms, I will need 7 units of cord blood to be transplanted to transplant a 70 kilograms patient. So it's difficult to find 7 different units that it has a good compatibility to the patient. So we rather use bone marrow or peripheral blood in adult patients. When we have kids or pediatric patients, then we can use cord blood, because obviously the weight in the pediatric population is low, or and we can use less cord blood units. And also the cost is an important issue in this type of transplant, because most of them come from another parts of the world. The type of transplant, as autologous, I told you that it was the stem cells come from the same patient. Syngenic, the first bone marrow transplant in the world in 1956 by Dr. Donald Thomas and his group, is from a twin. When you have identical twins, it is called syngenic transplant. And the allogenic transplants can be divided in related, non-related, or haploidentical. So again, when it is related, related is from the family, a sibling, either brother, sister, that is 100% compatible with a patient. Non-related is, we don't know, but there's nothing there. It is not a family, a family guy or a family people. You can have a donor in any part of the world. There's a registry that is called the BDMH registry that has more than 19 million in a database, and we can search a donor for our patients, and then it will like give you the whole list of the most compatible patients, donors, sorry, for our patients. And it will like display how what is the amount of compatibility, the percentage, and then we can choose from there if we think that it's a good option for a patient. We can like bring cells from another part of the world, from the US, from Europe, from Asia, from whatever. And haploidentical, as you may as you may recall the other classes, when you speak about haploid cells or diploid cells, we have in haploid cells we have only half of the chromosomes. So haploid is like 50% of compatibility, and this can be done by the mom, the dad, or any of the siblings, either sister or brother. But as I told you, it's a high risk transplant. The rates of infections or complications is very high. So but it is an option also for the patient. It is an urgent transplant. We can also do that type of transplants. From all these we are mentioning, the we have done from autologous, we have done a lot of autologous transplants. We have done syngenic. I have not done any syngenic transplant. Allogenic transplant I have done, and from related, non-related, or haploidentical. So it is, as I told in the very beginning, it is a reality now, and we can try to make the best option of treatment for the patient with the best possible donor, trying to cure our patients with a low rate of complications. More or less, this is what happens with the donor or our patients. First of all, we have medications that can stimulate the production of stem cells. As you know, stem cells live inside the bone marrow, inside the bones. So we use medications to allow the cells to go into the flow and the circulation. Then from there, we can separate through apheresis and have a harvest of these cells that is gonna be used some days or even weeks after the collection has been done. So I'm putting an example here. For example, we have a filgrastim injection in the donor or the patient. Then we have the harvest. We separate the cells through apheresis, and then we can either do things. We can like freeze the cells at -80 Celsius in liquid nitrogen, or we can use like the fresh cells. When it's allogenic, we can like send the cells to the patient right away to do the transplant. Then, sorry. Then we have here, for example, the infusion. This is called day 0 when we transplant the patient or we infuse the cells. It is like as a blood transfusion. We use a vein or a central venous catheter to infuse the cells. We don't go into the bone marrow and inject anything. It's just like a blood transfusion. And then we wait until 15 days to have a full recovery of the cells. Then from the day 0 that we don't have any of cells, the patient is with empty bone marrow. We have to transfuse red blood cells, platelets. Meanwhile, the patient recovers, but it will take at least 2 weeks for this to happen. And after the day 15 post-transplant, then the new cells are doing their function, and they are like recovering all the hematopoiesis of the patient, either if it is autologous or allogenic. Then we have this concept that is called conditioning regimen. The ideal is that it could be an engraftment enhancer, maximum malignancy eradication in terms of malignant disease or blood cancers, and with a minimal toxicity in terms of liver or kidney toxicity. So conditional regimen is like combination of chemotherapy and radiotherapy, or both, or one of those, to 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 eradicate all the leukemia cells that can be residual, and then to make space to empty the bone marrow, empty that space for the new cells to come and go into the new bone marrow and start doing its work. So we have different types of condition regimens: myeloablative, non-myeloablative, reduced intensity, or reduced toxicity. Um, we can choose what type of condition regimen and intensity depending on the age of the patient, on the physical status of the patient, and obviously and in how the disease is at the time of transplant, if it is controlled or not controlled. If, for example, the patient has leukemia and still has 1 or 2% of cancer cells, then we will encourage the transplantee to forgo to the myeloablative conditioning, because it is a more aggressive conditioning. It is more chemotherapy, more radiation to kill at most or the whole the cells that are still there. If the patient has 65 years and he's in a good conditioning, physical status, then we might go for a reduced intensity conditioning regimen, because a 65-year patient, we will not support what a 10 years a patient can also support. Then this graphic, what says is like we have the most aggressive. Here is myeloablative, like the reduced intensity, and non-myeloablative. So we have the pancytopenia is as it goes to the right, it's gone reversible, but and then the stem cell rescue, as you go having more and more toxicity or more high dose of the chemotherapy, we will need more cells to recover that patient. This number is amazing. It's like 70 diseases can be cured by a bone marrow transplant. But you can say, well, in my hematology class, we only see AML, that is myeloleukemia, lymphoblastic leukemia, chronic or acute. But how it says 70 diseases, doctor? How is that? So yes, we have like um, some diseases are like enzymatic. Enzymatic diseases can be cured. Some immunodeficiencies can be cured by a transplant. Even some malignant tumors like kidney cancer can be cured by a stem cell transplant. So we have hematologic diseases, oncologic diseases, and non-hematologic diseases. And you can see there that we have like autoimmune, congenital, genetic, from deposit, or in the microenvironment of the bone marrow. The whole groups of diseases can be cured by a transplant. Um, in this graphic, what I'm trying to share with you is that as the talk says, is stem cell is cell therapy and hematopoietic stem cell transplant. So imagine that you have autoimmune patients, like for example lupus, rheumatoid arthritis, or multiple sclerosis patients. So these diseases are autoimmune. As you may know, most of them has they have lymphocytes that that they are attacking the patient. I mean, depending of which disease we are talking about. But the concept of doing this type of treatments, that is called an autologous stem cell transplant, can control the disease or the autoimmune disease in a great manner, even better than a lot of immunosuppression that the rheumatologist or the neurologist can give for the patient. So, for example, that you have a patient with lupus in here, that the rheumatology has given like 3 or 4 different medications, like prednisone, acetropine, chloroquine, or mycophenolate, or whatever, not for immunosuppressive drugs. But they are not doing very well. The kidney is not too good. They have the skin with malar rash and a lot of activity of lupus. So we take this patient into a stem cell manipulation. So we use cyclophosphamide for 2 grams per kilo for 2 days. Then this is called mobilization. We take the cells, then give a conditional regimen that is used with cyclophosphamide and fludarabine, or thymoglobulin. Sorry. No. Oh, oh, there you go. Here, thymoglobulin here. I don't see the mouse. Here. The condition regimen with the chemotherapy. And then we provide the stem cells again here. And then we will see by the 15 days after the stem cell infusion. Obviously, these cells are from the same patient, but what we did with the autologous stem cell transplant is that we control the disease in a better way. Even we can reduce the amount of drugs that are needed. Like we can drop the prednisone from like 100 or 50 milligrams to 25 or 10 milligrams. So this also can be done in diabetes type 1. As you may know, diabetes type 1 is a autoimmune disease. Almost any autoimmune disease can be controlled by stem cell transplant. Obviously, as we know, autologous, it is not curative. It is important to say this. It is true that it is not curative, but as you see in this graph, in this slide, we can see we have after the transplant, the patient has an immune system reconstitution. A lot of reactive T cell species that were like very high in the patient before are dropped into nothing. The best example to understand this is when you have the computer that doesn't work. You know, they have this button that is called the reset button. So what we do with this is we reset the immune system of the patient. So most of the times after these type of procedures, the amount of immunosuppressive drugs that it is needed to control the disease is very, very low. And for example, in my experience in diabetes type 1 patients, a lot of them will be insulin free for at least 1 or 2 years. It is not cure, but you can delay the for example the insulin need for these type of patients. Um, this also is part of the same concept. We're like talking about the autoimmune disease. We have the selection of patients. Um, what in the last few years, like maybe 2 years, multiple sclerosis patients has been controlled with this type of procedures, with very good responses and very good control of the disease. So it is getting more often, and I think for in the next couple of years it will be I don't know if the first treatment, but it's gonna be maybe the second line treatment for this type of patients. Mm, so what we do is we can grab the cells from the bone marrow, then we can preserve the cells for many years. Even we can as I told you, we can freeze the cells, and they can be there for years. I mean, you can the best example for this is that the cord blood. Since the baby is newborn, we grab the cells from the cord blood and the placenta, and then we can freeze the cells for decades. So the cells are well preserved, and then when we need them, we can like defroze the cells and use for therapeutic procedures. So hematopoietic transplant has also adverse events like infertility, menopause. Some medication can be cardiotoxic. A lot of hormonal changes. So we can have like as we mentioned in very young people, very premature menopause, infections. That is one of the main troubles in hematopoietic stem cell transplant. And also in some cases, we can have autoimmune disease secondary to transplants, and even secondary neoplasms. Like for example, some patients can after a transplant, they can do a they can have lymphomas or another type of neoplasms like kidney cancer or other type of cancers. So after this talk, I want to share with you as conclusions and a message to take you home is that cell therapy and hematopoietic stem cells can cure more than 70 diseases. We only mentioned some of them, but they're like a huge list and can be treated by this type of procedure. An interdisciplinary team is needed, nurses, infectious diseases doctor, obviously the hematologist, and another nutrition doctors. In 60 years or more old patients, we need sometimes gerontologists or geriatric doctors, and we need to democratize cell therapy and transplant. This is to be like uh, um, to share this information, to make like people know that it is real, that they can be treated with this type of procedures. And also in Mexico, it is a reality also that you can become a donor. There are some international registries as Be the Match, and you can join that type of registries and save life in Mexico or in any latitude of the world. I don't know if you have any question. I'll be glad to answer your questions, and I want to say thanks for your attention. Hopefully you understand me, and thank you, Carla, for your time.
No, thank you. Thank you so much. I think it's a really interesting topic because there are a lot of things that we don't know. So there are questions on the chat. I don't know if you want to read it. One is from Ana Karen Moreno.
Uh-huh.
She has questions about the costs.
I don't see the question. I don't know.
No?
There.
Okay. She's
Here.
asking about how expensive is the transplant therapy and
Okay.
how many times can this procedure be performed maximum?
Well, um, talking about the cost, it will depend on if it is an autologous transplant. For autologous transplant in a private unit, like a private hospital, can cost between $20,000 to $30,000, more or less 500 to 400 to 500 thousand of pesos.
Oh,
Yeah.
it's
So,
something.
sorry.
It's something in this
Yeah.
kind of therapy is done in the Hospital Civil or
Yeah, so they have a pediatric unit in Hospital Civil Nuevo, not for adults yet. Um, Only in Mexico City they have public hospitals that has adult patient units for transplant. Uh, and how many transplants can be done to a person? Well, there's not a number. In my experience, I have done like 3 transplants to the same patient, but I have like participated in one patient that received 5 transplants. So it is not wouldn't have a number. It will depend on the status of the physical performance of the person. If he's like fit, he's still strength to support another transplant. It's what is more important than the number.
okay. There are a lot of questions. We have 3. We
Uh-huh.
have one of Carla Islas. I don't know. You can read it. I can say it. It is possible to use periodic stem cell transplant as a way of controlling type 1 diabetes patient in the long run.
Okay. Yes. So when we have a patient with diabetes type 1, we choose the first of all, they have to have the anti-GAT1 antibodies, at least more or less than 1 year of the diagnosis is important, because if they have more than 1 year, then it might the the cells in the pancreas might not be enough to be recovered. So I haven't done any transplant more than 1 year of diagnosis of the type 1 diabetes. Yes, the answer is yes. One of my patients, 14 years old, he was transplanted again 3 years after. He was needing insulin. After the transplant, he dropped the insulin, and no insulin was needed anymore. And up to the second and or more likely the third year, insulin was needed again. So he asked us if he can go into a second transplant, and the answer is yes. He can go for a second transplant to see if we can control the autoimmune disease again.
Okay, really interesting. Michelle Cruz has like 3 questions
Sí.
about the DNA sampling.
Uh,
You can read it, or do you want me to read?
yeah, so this I already know about DNA
But,
sampling that BDMH does to add you to its list. But my question is, why do they need DNA rubbing on a swab cheek? Why we not use blood to get DNA? Okay. First of all, because in Mexico, BDMH has at least 56,000 Mexican potential donors in the registry. So it is not very first in the healthy condition to like grabbing samples of these 56,000 Mexican potential donors. It is more easy to like go to the university like Cutonalá, for example, or Tec de Monterrey or Univa, make a drive. Drive is you go in the campus, ask the students if they want to join the registry, and then you give the swab right away. They just like need with the swab the cheek inside the mucus of the mouth, and it is like it's more easy than having a blood draw. So that's why. But uh, as a matter of fact, when we go actually into a transplant, then we double check the DNA with a blood sample.
oh, that's really interesting. I think
Yeah.
it's less invasive. No. We have another 2 questions. Jesus Vasquez.
Uh-huh.
From the 500 to 600 transplant of bone marrow in Mexico every year, how many transplants do you make?
How many transplants do I make? Well, we have a unit that is either pediatric and adults. As you know, this year was a very bad year due to COVID. We couldn't make enough transplants, but last year we performed like 22 transplants in our unit. So hopefully next year we will increase the number as soon as COVID pandemic is better controlled.
Okay, thank you. Another question from Dr. Jenny Arratia. Hola, Jenny. What about adipose tissue stem cells and the replication in Mexico? That's a really interesting question.
Yeah, well, we don't use that type of stem cell cells for hematopoietic stem cell transplant,
Mm.
uh, and or cell therapy as we were mentioning. Yes, you can liposuction or like plastic surgeon procedures can manipulate the adipose tissue, and we can grab or you can harvest or take cells from there for another like procedures. Like it's more like regenerative medicine, uh, but not for cell therapy or hematopoietic stem cell transplant.
Okay. Anyone has another question? I have 2 questions, to be honest. I have a question is, what are the selection criteria for the donor?
Okay. Do you say in terms of join the registry or actually being a donor? Like,
Actually being a donor.
okay, first of all, if um, the HLA is the most important part. I mean, the compatibility of the whole HLA class 1 and class 2 different antigens. If we search for the 100% compatibility, but we allow up to 80% of compatibility in that amount. Below 80% is a high risk transplant, so we don't want that. Um, what also? There's not an age,
Okay.
but we rather take young male donors, because when you analyze the results in 5 to 10 years after transplants, seems to be that when you have a male young donor below 35 years old, the outcomes are better. Why? We are like searching why it's that, but it's like we also make IDMs, that is infectious disease markers like HIV, hepatitis B, C, syphilis, Chagas, and a lot of diseases that uh, can be transmitted by a transplant, to choose
Okay.
which is the best donor. We,
Obesity is not
no,
a
diabetes
issue
not,
here.
hypertension not, obesity is not an issue. What else? The weight is not a big issue also, but we like try to stick to the blood bank standards for having a donor also. It's more
Uh,
likely the same.
okay. We have another questions. We're almost done, Tony. Hold
Oh
on.
yeah.
Why don't you try to clone the stem cells? It's expensive, it's difficult. Why don't you do it?
Well, I don't know if clone is the disease, but expand, yes, we can expand cells. Um, this in the Minnesota University of Minnesota group, they can do that. They expand cord blood for adults. As I told you, you need like one cord blood unit for each 10 kilograms of the patient. So in some of them, uh, they harvest the cells, and then they put cytokines, and they expand the cord blood from 1 unit into 2 units,
Mhm.
and then so on. Yes, it's very expensive. That's why I wouldn't do that. And then if we have pheresis or stem cell collection directly in the pelvis, and then we can have a better harvest in terms of number of cells. It's better to do that.
Okay. Well, I have one last question.
Yeah.
I don't know if you have read, done, or know something about using stem cells in inflammatory bowel disease or something like Crohn's disease. Uh,
Yeah.
it is done.
Yes, I haven't done that. The Elder and the European League against Elder, against rheumatic disease. Uh, you can also do in ulcerative colitis or Crohn disease, but only when you have failed to like 2 or 3 lines of treatment. You can like try to see if this side of treatment can be done. But what I can tell you is that in some reports, seems to be uh, the rate of complications is like 1 or 2%. I mean, like great infection, sepsis, or whatever, and you can gain a lot of control of disease. I have done in lupus, diabetes type 1, sclerodermia or systemic sclerosis in the skin. Uh, I have done in also in multiple sclerosis, and I think that's it for the
That's a
moment.
lot.
Yeah,
So, is there another question, guys? You can write it down or you can open your microphone if you want to. Remember that these webinars are for increasing our knowledge, but also for improving our English. You can listen in, writing, or speaking also. So, if there is not another questions, well, there is nothing else to say. So thank you so much, Tony. It was really an interesting topic. It's a great information, and there are a lot of things that we don't know, and we can talk about this later. And we have another webinar, so you can be invited.
yeah,
And
of course.
Yeah, next year we can invite you again, and I hope you can say yes.
I'll be glad to share with you new information, and have a great night. And thank you again for the invitation.
Yeah, thank you. So thank you guys. Thank you everybody. So good night, and we see you next Wednesday at 7. So goodbye. Thank you.
Thank you.
Bye.